Thank you, everyone. Thank you for Red Health for having me. Thank you all for coming. I'm trying to make this presentation not as formal. So simply, I'm happy to take any discussion, any question about any slide, anything you think of. I'm sure every one of you came today to get something from the talk, so I hope you will find it useful. I'm new to the state, so I'm moved from other states. I've been initially in Victoria, then Tasmania, now here since January. So I'm still getting my head around the legal aspect of Queensland. So you can correct me if I'm saying something wrong. The topic actually was chosen by Red Health, and I found it was a very interesting topic because I'm sure it's one of the challenges for me as a clinician and for most of you. I'll just start initially just with some basic medical stuff, not actually anything legal yet, because I think if we start to understand some of the medical component of it, it will be easy to apply the legal bit on it, and it will start to make hopefully more sense. So the definition of pain is simply, it's an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. What I want to highlight from all this complex definition is simply pain is subjective. Sometimes we cannot prove if someone in pain or not. So we have to bear in mind that the pain at the end of the day is a subjective thing, and we need to take it subjectively. There is a sensation, so pain is an unpleasant feeling. There is an emotional component to it. Someone who's in pain, especially persistent pain, they will not be happy, they will be tense, they're not sure what's happening, depressed, not sleeping well. There is a lot of emotional component to that. But see here, it say associated with or resembling actual tissue damage. What is this definition saying? It doesn't necessarily to justify someone in pain that we find something on a scan. They may still have pain, but we cannot catch it on a particular investigation. What's chronic pain then, or persistent pain? Any pain over 3 months. So once the pain starts to be lasting more than 3 months, it becomes classified as a persistent pain. Some will ask, why particularly 3 months? Simply because most of the healing in the body from any injury, any trauma, any surgery shouldn't last more than 3 months. So if the healing, whatever happened with it, is complicated or something happening and the pain is not going away, after 3 months we'll start to say it's a persistent or chronic pain. Physiological pain, that's the pain we all know about. If I'm walking in the street and a nail went in my foot, it's good to have pain, so I realize that something went in my foot and I will look and do something about it. That's a protective pain, and that's usually acute pain. Someone who had something broken, something bruised, have cancer, have appendicitis, anything which will trigger that there is something wrong here, the alarm will get triggered and tell you need to do something about it. So that's not bad. The one which actually we start to say pathological, like it's becoming a nagging or an issue on its own right, is the pain which is simply someone have a nerve damage. We cannot fix the nerve. They will keep getting pain from this nerve sometimes. That will become a nagging pain. We cannot do anything about it. It's not going to kill the patient, but it's simply we cannot also stop the pain from it. Or there is something you may have heard or coming across recently. In a simple way, you can call it dysfunctional, that there is a glitch in the system or in the nervous system. Or the medical term for it, central sensitization pain. What's that? The easiest way to explain it. A car alarm is meant to be triggered if someone tried to break in. But you sometimes see some cars which will get triggered by someone just walking by the wind. That's similar to our nervous system sometimes. It becomes just triggered by something and it doesn't want to stop and it keeps going. We call that central sensitization. So what will make the pain then, or the nervous system become very sensitive to the pain and it doesn't want to let it go? We found that if there is an ongoing inflammation in the body, it will keep nagging the nervous system and the alarm will keep going. We talked about the nerve. If a permanent nerve damage happened, the alarm will keep going. But what we don't know, or we start to know much about recently, is simply what we call impaired nervous system inhibition, which simply the alarm got triggered by something, a fall, a surgery or something. It was meant to heal and settle down within a few weeks, within a few months, and the alarm keep going, and the nervous system keep going and giving us more pain. Why? It's simply the nervous system itself is struggling to shut the pain down. We call that impaired inhibition. So the next question will be, what makes the brain do that, or our nervous system struggle to shut the pain down? Genetic. Sometimes you ask some people and you tell them, a chronic pain patient, do you have anyone else in the family have chronic pain? And you tell your dad was like that. My grandmother was like that. My grandfather was that. So we start to know that there is a genetic component. To what extent, we don't know yet, but definitely there is sometimes a genetic component to the pain. People who smoke a lot, people who are not sleeping, but I mean by not sleeping, missing a night or two will not do much. But I'm talking about people who are not sleeping for weeks and months and things like that. Think of it like the computer. Imagine you have a computer at work, and this computer, at the end of the day, you shall shut it down so that the next day you come and put it on again. If you left it on all the time, you don't give it any rest, it will start to glitch. The same with our nervous system. Our brain needs sleeping. And if we didn't have enough sleeping, it can sometimes glitch. Coffee, we all love our coffee, but some people, their body is sensitive to it, especially if they're drinking too much, because the caffeine and other things in the coffee are stimulant. They keep pushing the brain. Keep going, even if the brain wants to shut down or rest. That's artificial sugar is a tricky one because we all have artificial sugar nowadays, but definitely some people, artificial sugar can promote inflammation in their body. And part of this inflammation, we start to now realize that it can cause microinflammation around the brain and the nervous system, and that sometimes can make the brain struggle to shut down pain. I had some patients, I just suspect something, or I tell them, let's try it, maybe it's the problem. They stopped, they were drinking a lot of soft drinks and things, and they just stop it, and the pain start to improve. It's not common, we don't come across it a lot, but it does happen. And the main one, which is the main topic here, ongoing mental health issues. So what mood or mental health has to do with pain? That's what we talk about the next slide, I think. Or we'll talk first about the pain presentations. So when people come to us for an assessment of pain, we put them in a category as doctors. Nociceptive pain is the pain all of us know. It's a tissue pain. Call it tissue pain. Someone has something bruised, something cut, something broken, they will have pain. That's the simple way of understanding pain. That's nociceptive pain. Neuropathic pain is simply nerve pain. Any inflammation or any injury to the nerve. Pain sensitization, we talked about it, and we simply said that this is the sensitivity of the nervous system to the pain itself. But the other ones which sometimes can become difficult to recognize or sometimes even diagnose is, forget about this big term, simple way, psychogenic pain. Can people, what do you mean by psychogenic pain? Do people imagine pain? No. No one imagine pain. And no one will start to think that they are in pain, but they are not. We are not aware of anything like that. But what we are aware of, that a lot of people may have a mental health condition, depression and anxiety, and rather than presenting with it, with emotions and saying I'm depressed or I'm anxious, they will present it with physical complaints, including pain. The best example for that, Sometimes we hear a 12-year-old boy or girl keep presenting to the emergency department with abdominal pain. The GP keep doing investigation, nothing showing. They keep presenting to the emergency and nothing showing. And they start to say, what's wrong with this kid? He's making it up. He just, after a secondary gain, like some reward from his parents or attention seeking. Sometimes not. Maybe that kid is depressed or anxious. They don't know how to express their emotions. They cannot know yet to say, I'm depressed, but they're presenting it or alerting us by having physical complaint. The bit which we sometimes come across, especially in your setting, is people who are actually conscious of the pain. What we mean by that, malingering, we try to avoid the term, but simply someone making it up. They are not in pain, but they're after some secondary gain, some compensation, whatever, by saying that they are in pain. This factitious disorder is simply, they are not after money. They are not after compensation. And even there is nothing going on, there is no legal stuff, there is no work cover. So why are they making up the pain? To be praised. You are a sufferer. You are a good person. Or, for example, they keep selling their kids, for example, or their other family member pain. They're trying to get praises, attention seeking, but sometimes there is nothing. There is no pain in the first place. How common is that? According to research, it's 5%. So any patient who presenting with persistent pain, roughly we think it's 5% are making it up. But again, because it's subjective, who knows? It's hard anyway to catch that on a research even. But we think it's roughly 5%. Any questions so far? I think it will not work because simply some patients can know how actually to trigger their heart rate and blood pressure. Some people can have some drinks or things like that, coffee, whatever, to put it up. I think it will be, and it's, you cannot say that it just will come from pain. You may have a fight at home and it will make the blood pressure and the heart rate will go up. So it will become still very unspecific what's happening. I don't think from a medical point of view you have a ground for that. And it looks like we're trying to catch or get the patient caught. And it will send the wrong message again, we're not believing you. And that may add more trauma. So I'm not sure whether this will be the case or not. I think sometimes when we're desperate for any objective tool to diagnose or confirm the condition, we can get to that. But from a medical point of view, I don't see the grounds for it. So why, in general, someone pain will persist? Why the pain will persist? We talked about the sensitivity of the nervous system, fine. But think of the pain, it sometimes can become a language. If someone has been living with chronic pain for 10, 20 years, the brain already got accustomed that there is pain every day. There is routine around this pain every day. The brain already is speaking the language. Sometimes it's very hard to let the brain forget that. It's similar to people who get addicted. Sometimes you come to the stage that you're telling them, why are you doing it? Or why you continue? And they tell you, I don't know. It becomes a routine. Pain sometimes can become a routine, but actually there is a structural changes happening in the brain. It's not just the habit. There is changes happening in the networks in the brain to make the brain already adapting from a structural and functional point of view that the pain is going to stay. We're not aware which genes yet. There is a few of them we start to find, but there is a lot of other things which we don't even have a test for. And at the moment, we're getting it from just history. I will answer this question and remind me if I didn't when I come to the slide, which is the overlap between the pain and the mental health illnesses. Because that's actually may answer your question. You're not going to tell it from the genetic testing, but you will tell it from something else. We said that if someone feeling low or depressed, or there is a lot happening with their mood and mental health, that will make the brain not able to shut the pain down. And we'll explain why soon. And again, we talked about if there's something still happening to trigger the system, there is still a chronic inflammation or there is a nerve injury. Okay, so why there is overlap between mood and mental health and pain? Is there is any medical explanation for that? Yes, there is. We start to understand that. So we now have something called functional MRI. It's pretty much an MRI, but it's a little bit more fancy. We just use functional MRIs for research, but it tells us actually what's happening at a brain level from a lot of things, including metabolism of the brain. We found that people who have depression and anxiety, it triggers certain areas in the brain called the limbic system and the prefrontal cortex, which is simply our emotional centers in the brain. We all know that. But what's the interesting part? The interesting part is that actually chronic pain activate the same areas. So the same areas in the brain are triggered by either the chronic pain or mental health. That's interesting because we're talking about the same area in the brain. Not acute pain. Acute pain is triggered in a different area in the brain, but I'm talking about chronic pain. Chronic pain and mood are pretty much stimulating or affecting the same area in the brain. More interesting, we start to test some substances which the brain uses to slow down pain or regulate pain, and the brain also uses the same substances to regulate mood. Some of the substances we managed to find serotonin and noradrenaline. So even the brain is using similar substances to do two functions: regulate our mood and inhibit or slow down the pain. So we're talking about same area in the brain, same substances. We found also people, especially PTSD and anxiety, the sympathetic system, which is part of the nervous system, which is the fight or flight, always triggered, especially by people, depend on more with anxiety and PTSD. Some people are depressed will still trigger the sympathetic system, but again, it depends on what symptoms of depression they have. But I mean, most of the psychological factors can trigger the sympathetic system, and what the sympathetic system do? It compromises the ability of the brain to slow down the pain. So now we start to understand maybe there is overlap or disconnection. So what we see in real life, people who are depressed, anxious, will feel more pain, and sometimes even they will not recover. And I'll give you an example. Two people or two patients went for the same operation, for the same type of pain. One of them is very keen to go back to work. Everything before this broken bone happened was fine in their life. They love work, the family is good, everything is going well. The other patient have the same injury, they need the same surgery, but before this happened, they were depressed, anxious, a lot of things happening at work, the family is upside down, and there is a lot of things happening. Both will go to the same operation, maybe by the same surgeon. One of them will recover after a few weeks, the other one will continue with the pain. Why is that? Because most likely, what was happening before the pain started? All the package of the mood things and whatever happening in their life affected all these chemicals and areas in the brain. So the brain, when the pain started, the brain is struggling to shut the pain down. So the pain continued. We found that people who are very anxious usually report more pain. And sometimes we say, because they are just very touchy and things. No, they are actually feeling more pain because they keep pushing on their sympathetic system and it's triggering them to feel more pain. We found that people who exaggerate, you tell them, are you looking back to work? No way. The doctor said, I will be out of work for life. these people will never go anywhere because they are already putting the seed to the brain. It's not going to work. We're going to live with the pain. And sometimes in real life, not with the independent assessment, when the patient come in the room and tell me, I'm going to live with the pain, I told them, if you're going to live with the pain, you shouldn't come here. I'm the wrong person because simply my job is to try to help you to move the pain a little bit out of the way or get rid of it. But if you're already putting the seed to your brain that it's not going to go away, my ability to help you is very limited. I think I turned this. People who are not coping with the pain. I usually say sometimes to some patients, you need to be able to fight with the pain. People who are actually in a fight mode, I need to push this pain away from my way, do better. People who start to surrender to the pain, nothing usually improve. But some people actually try to cope by falling into addiction. And I think there was one of the questions from the audience about opioids and addiction and all these bits. I'll just talk about addiction in general and pain. It's very important that when a pain patient comes to us, that we recognize if there is an addiction problem happening already or not. Unfortunately, most of the pain specialists are not good at that. Because in pain, we are just trained to look for the pain, maybe some psychological bit, but addiction is difficult. I had an advantage while I was doing my pain training that I was offered to do addiction as part of it. And I took it. Because simply I said, I need to see the patient from another angle. How they fall into addiction, how I can pick that they are already addicted, and what we can do about it. Because unless you diagnose that there is an addiction and do something about it, the pain is not going to go away. Why? A lot of things. Sometimes it's hard to tell. It's becoming the chicken and the egg. Which one is causing what? Hard to tell. Sometimes it can also be because when people are in addiction to certain substances or drugs, if they miss the dose, they go into withdrawal. And the withdrawal, what it does, it pokes the nervous system. It triggers them. And that can trigger more pain. And they become struggling. I don't know what to do because every time I try to get away from the substance I'm addicted to, I get more pain. And other things, but the pain can go up. Again, they are not usually sleeping well. They are busy looking for the next dose, how to source it out. The substance they are using make them feel down after whatever they got from it, back to reality, or whatever substance they are using. Alcohol is one of the common substances which make people depressed on the long term. It makes people numb initially, so that's why they go to sleep or try to numb their emotions, but it sometimes, on the long term, causes more depression. So it becomes hard to tell what's happening and what's causing what, but it's very common. What about opioid addiction? Morphine and all these bits. Can we get how people get addicted? That's research. 1 in 5 who will be on opioid for a long term, and a long term, I mean by long term, over 3 months. 3 months onward. 1 in 5 will fall into addiction. So the government at the moment is trying to push. There is a new guidelines which they say that opioids are not indicated for management of chronic non-cancer pain. So any patient who have persistent pain which is not cancer related, they don't want to give any opioid from the start. You don't expose the patient to it, and then when they fall into something, then no one wants to help. So they say get away from it, but patients sometimes are nagging. Doctors want to please the patient, or the doctors feeling helpless. What we can do, we give them opioids. So the government now start to step in. If anyone start to be on opioid after 3 months, the government will start to ask, there is a monitor system, what's happening? Why patients taking that for long? Can someone else endorse it? Can another doctor state what's happening? And now there's a review. The patient has to be reviewed by another doctor every 12 months. People who have mental health disorders, especially people with borderline personality or antisocial personality, we found actually, according to research, they are very prone to addiction. They usually get hooked to drugs quickly to the extent that 80% of them fall into addiction. But back to the question, and that's a very good question. We found that this is statistics, that people, if we prescribe to them for 3 months, that 50% will continue for 5 years, but not the 50% will get addicted. They simply going and using it. And you tell them, why are you using it? Because I was not told anything else better can work. No one else offered me anything else. Maybe it's doing something. Maybe it's taking some of the pain away. So they are not addicted, but actually they continued on it. Like the elderly. Usually very hard to get someone who's 70-year-old to get addicted to a drug, but they will still be part of that 50%, which will continue for 5 years. But why opioids particularly is very addictive? Because simply it distresses the patient. Yes, we know about euphoria, but not everyone who will take opioids will feel up to the moon. But a lot of people will take it and they feel that their anxiety is a little bit less. They're more calmer, they're sleeping better. So initially some patients fall into addiction by accident. It's our fault. We don't tell them what they should expect from this drug. You prescribe it to them initially for pain. They went home, they took it, and it made their emotions feel better. There was no agreement how long we will stay on it, what's the problem with this drug. We sometimes don't talk to patients, what's the side effects of this drug, like any other drug we will prescribe. And then the patient start to do their own things. We are just busy. You need more, take more. And things continue, and patients fall into the addiction without anyone noticing. But there is a difference between addiction and dependence. I don't want to expand too much on addiction, but simply addiction, the definition of it, when the patient loses control. They start to live for the drug. Dependence is different. If I took, or any one of us in the room took opioid for a few weeks, you become dependent on it. We mean by that if you stop it, you will get into withdrawal, because the nervous system will get in a shock mode or become anxious. Where is the drug? It doesn't mean that you are addicted. It doesn't mean that you lost control over it. You become, let's say, physically dependent on it. But you're not addicted. Addiction is once you lose control. You're living for the drug. Pain education programs. We found that this is, and the research is showing the same, it's one of the useful tools for patients, chronic pain patients. Why is that? Because we found that part of the problem is that patients are not sure themselves what's happening. They go to different doctors, they're saying different things, everyone different opinion. There is a lot of complex things happening, work cover, insurance, whatever. A lot of things happening. They're getting mixed messages. Some people just want to understand how does the system work, why the pain will persist. So we tell them similar things to what we're talking about, but in a more simpler way and more detailed. And usually these education programs have not just doctors, have sometimes nurses, physiotherapists, psychologists, occupational therapists, and everyone talk to the patient from their own experience and own background. We found that once patient knows what's happening, a lot of them do well or do better. I had some patients, interesting enough, they came in, I didn't offer them any treatment. Sometimes I'm not even sure what to give them. They tried everything, but I just explained to them, maybe the cause of the pain is that, and that's what's happening. And they tell me, thank you, job is done. I don't want anything else. And they move on. They just want to have some confidence to realize what's happening. Because a lot of people think as long as the pain is continuing, there is ongoing damage happening in the body. We now start to realize not necessarily. Most of the time it's not. There is no ongoing damage. Even if we left the pain, nothing else will happen to the body, but it's not fair to leave you in pain, because pain is pain.
Multidisciplinary approach with allied health.
You actually can approach that by two things. Sometimes with just general pain education program that we start, and especially physio are very good. Yes, it comes to that sometimes the nervous system, because remember, this nervous system has become very triggered, very sensitive. The brain knows if there is pain, we shouldn't move. We should protect the area. So if someone all the time in pain, the brain will keep telling them, you shouldn't move. You shouldn't move this part. There is pain in it. You shouldn't move. To the extent that if they did anything just simple stuff, the brain gives them more pain. And to unfold that and tell to the brain, it's all good, it's just faulty alarm, there's nothing else happening in this area, you can do that through general talk, but just telling them that this is a possibility. And then patients are smart. They go back to their GP, tell them, can you send me to someone, a physiotherapist or occupational therapist with interest in pain to tell me more about this? I heard it in this program. Or sometimes you can refer to a private or an one-on-one physiotherapist, and they will go through that with the patient. The problem is psychologists don't have like a qualification called pain psychologist. They have special interests. Some people get exposed by experience or their work environment, or they start to go read more about chronic pain. But there is nothing called pain psychologist. So a lot of psychologists sometimes don't know what to do with pain patients or what to give them as an advice. And the same applies to physio. Physio who are just hands-on, they don't usually do well with chronic pain patients because they will start to push them as if they are acute pain patient. Come, let's do these exercises, let's do this and that, and the pain and the nervous system will flare more pain. You don't want to see the physiotherapist again. It went bad. So you need sometimes people or physiotherapists who did some study or have interest or have experience. The advantage of the education program, usually when you get people to run this program, they are exposed to that and they know what that and they're talking the same language. While when you send sometimes to general people, unless they have any experience with chronic pain, sometimes it doesn't go as well. I'm not trying to sell a pain education program as well, but it's simply, and sometimes people run it for money, to tell you frankly. I'm telling you the truth, but it's simply, it's not meant to be for that. It's actually a very important role it has. Ask the patient. If you have a talk with them or you have a personal relationship, what's happening in their life?
Yeah. So we're looking at their psychosocial...
They will tell you if they trust you. And a lot of people just want someone to listen to. We can sometimes get a lot of information, but we don't ask. But if we just spend the 5 minutes, you can get a lot of information which will save you a lot of time down the track. Yeah. Ask. And patients are smart. They're happy to talk to someone if they trust them. Or they feel just comfortable, they're not going to be judged. And sometimes you can highlight to the doctor, I was talking and after the permission of patient to my client, and they mention or raise the issue that there is something happening here. Some patients are also against that because they are scared if you diagnose them with any mental health illnesses, it will be blamed on and they will not get any compensation for the pain itself or for whatever injury they have. And it becomes issue of they're trying to push you away even from diagnosing them with any mental health illnesses or because of the stigma around it. I found this is less of a problem when you have a patient in the room. The patient in the room wants help. So they are happy to hear you and go with you until they see where you're going to take them. But the problem with the patient who are coming from worker cover or insurance or something, there is another agenda happening or something behind the scene happening and you are part of it. So whatever you will say, sometimes they even resist you. I don't want that. Even I don't want you to mention it because it will affect my claim. And that's when it become blurry. Even from a medical point of view, you feel, am I actually doing medicine here or I'm just going to go proving and disproving? And sometimes you feel it's draining you as a doctor or as a clinician. People who want help, and if you start to give them, that's what we know, and that's why we need that. If you tell someone, go to the physio, and you don't explain why we need physio, or why we need to talk to a psychologist, usually will not take it well. They will take, you're trying to make me tell that I'm crazy and I'm making up the pain. I'm not going well with that. But if you tell them actually what we explained, we're talking about the same substances, same areas in the brain, that's why we're doing that. I sometimes tell people you need to see a psychologist for people who are not depressed, not anxious, but simply they are not coping with the pain. And the pain starts to drain them down. Sometimes we give some antidepressant as a pain medication, and people tell, why are you giving an antidepressant to someone who's not depressed and how it will clear their pain? Simply because the antidepressant, certain antidepressant, lift these substances up artificially, Doesn't matter if it's going to help their mood or not, because the mood is not affected at the moment, but it may help the brain to slow down the pain. Hence why we sometimes put some pain patient on antidepressants. So this is something called NICE guidelines. It's in the UK. It's very highly regarded guidelines here in Australia. So things which we don't have sometimes something about it here, or it's not clear enough, we usually sometimes refer to NICE guidelines in the UK. For the first time in 2021, they used to dismiss few things, which I will tell you when we go through the slide. But it's interesting what they're offering for chronic pain. If you think here, can everyone see? They're putting physio and exercise first, and physical activity, psychotherapy or psychological therapy, acupuncture. That's the one which was dismissed before. For the first time, they put it in 2021, and they're putting it before what? Before medications and procedures. I know maybe someone wants to ask how acupuncture meant to work, or no one wants to ask that. It just does. It's like anything, it's not going to work for anyone or everyone. So if someone's saying that again, it's not right advice. But how it meant in a nutshell, what we're trying to do with the antidepressants artificially, the acupuncture is doing it naturally. We're trying to lift the chemicals up to help the brain to slow down the pain. But you can do it naturally by acupuncture, or you can do it with medications. So anything with trying a substance or a drug or in local or nerve blocks, it will, or medications, including opioids and all these bits, and Lyrica, all the favorite stuff coming down here. Pharmacological. It's not changing the chemicals. It's trying to lift these chemicals up. Okay. I know people usually ask, this is something old. How is doing this and how we know it? It's a big story, but simply, I think the way they realized that it can do that by observing. They were trying on people and seeing what's happening. But again, I'm not trying to sell you acupuncture. That's actually the guidelines. I'm one of few pain specialists in Australia who say it and do it and believe in it. So again, I know that you will get mixed messages from everyone. That's why I'm not telling you here my own opinion. I'm telling you what the guidelines are changing to. And as I mentioned, it came before the medication, but yes, exercise and psychological are coming up top. But also remember that there is more research done with these aspects rather than something like acupuncture. But what actually interesting me is not the order. What interesting me that at the end of the list is what we do as pain specialists. Which telling you sometimes why we fail. Like, because if you look at the list of what it can treat, pretty much what we're dealing with every day. Let's move on. Definitions, I think you may be better than me with definitions, so I will read it. That's the definition of the WHO for impairment, pretty much any loss of or abnormality of any nature, psychological, physiological, or anatomical structure or function. Permanent disability is simply when the disability continues, but it's simply no improvement or it becomes stable with or without treatment, and no improvement for the impairment by more than 3% for a year. Then you can classify as permanent impairment. What's disability then? It's simply the result of the impairment. If the impairment starts to affect the function, pretty much any restriction or lack of ability to perform an activity because of the impairment. This is maybe not more related to work cover people here in the room. If someone coming, how we determine if this impairment is actually from the work cover or the work injury or not? Simply work incident, and the pain or the impairment started after it straight away. There was nothing before the incident. Sometimes it cannot be as easy as that, or sometimes with the psychological bits and they're already ready for it and things, you cannot blame what happened at work by itself. But it's simply, you still can say that the work was the main factor. And there is a question you can ask yourself, and that's, I think, what maybe court decide upon, is simply, would this impairment have occurred if not for the work-related injury? So if the patient or the claimant was not there at that time and this has happened, will be they in your room at the moment complaining of that or not? And if the answer most likely they are, then you still say it's related to this. But when we actually assess impairment, or we say we think that the patient is impaired, we don't see what was said by the other doctors or the other clinicians or what will happen in the future and start to predict what will happen. We usually say what's happening in front of me in the room, because otherwise it's becoming very vague and gray. But what's the criteria before you can say I can do that? Simply, impairment has to satisfy the definition, simply that it's related to the work injury. And thirdly, that's Queensland. And you would see then in America it's a little bit different. There is a defined diagnosis. You say this is what, and there is something to prove it, and that's what caused the impairment. Because you will see in the next slides, pain by itself is not accepted as an impairment here in Queensland. Why? Because pain is subjective. So can you assess or justify more impairment if someone on medication? Yes. If you can prove that without the medication, the patient will be back to square one impairment. For example, someone had a head injury, they start to have epilepsy, they have been on epilepsy drugs. If we stop the anti-epileptics, they will usually have seizure. That still increase their impairment by at least 3%. But this again doesn't apply to pain medications. Because who knows why they are on it and justify it. Subjective. So the AMA, the Australian Medical Association version 5, they have pain-related impairment. You can assess someone and say that they are impaired just because they had pain. Yes, their criteria is still a little bit, they're trying it very cautiously, and there is a lot of restrictions, but they can do it to an extent, and simply they can even classify the impairment as mild, moderate, severe, or severe, and they can even, they have to justify on the report, is this impairment rateable or unrateable? What do we mean by that? If you said to the patient, your pain impairment is unrateable, the patient usually will think that you're implying that they're making it up or they're getting crazy and imagining the pain. So simply what they say by the term unrateable, it doesn't mean that. It means that simply the examiner is admitting that he or she is unable to determine that these restrictions or this impairment, which was reported by the patient or the claimant, was from a particular disease or injury, which they can justify on a scan or on diagnosing on examination. Because we saw now that with the type of pain, there is a lot of subjective pain component which are real. The patient is not making it up, but there is no examination or there is no test or investigation to confirm it. So they put that as unrateable. Very gray, and sometimes very hard to pick, especially in this context when there is secondary gain or potential secondary gain, who is actually real and who is not. So that's why Queensland and a lot of the states still ignoring that. They're saying no separate allowance for permanent impairment due to pain by itself. And simply, and this has happened in real life for one of the patients in independent assessment. I came to the conclusion that this patient is not real, or there is question mark about their credibility. So I come to the conclusion, if I ask this patient to move their hand or their back or whatever, they tell I cannot move it. If someone is actually not moving their arm and they're claiming that they are not moving their arm or their leg for 6 to 12 months, when you examine and look at the muscles, you shall see wasting in the muscles here when you compare it to the other side. But if I look and I didn't see wasting, I can see confidently you are making it up. And then if I say making it up, I'm not going to examine it. I don't want you to tell me I cannot move it, because I know that you will tell me that. And actually, the regulation allow me to do that. So sometimes in some of the reports, some of you will come and keep nagging me, why I didn't examine the range of movement? Because if you reviewed what I said, I'm not convinced that the patient have a complaint because there is no wasting in the muscles. Or there is, on examination, I can tell from the history, this patient telling me something they read on Google. They're not in real pain, because I hear every day a real pain patient telling me what they feel, and it's making sense with what I see. If you're telling me something and I feel it's not matching my examination, it's not matching the investigation, I have the right to say there is a question mark. And if you really want a real answer, you're using my own experience and exposure. I know that some people are maybe opening a can of worms by saying, I don't think that there's a problem here. But I have the right, because I'm independent. Secondary what? Secondary.
Let's say depression, secondary to pain.
It's not me, it usually will be psychiatrist. So simply the patient can be assessed by a mental health clinician,
So you make a referral.
and they will assess the patient from a mood point of view. And that actually, they can justify that. But the pain itself, they can say that the pain is contributing to the problem, but they don't want a pain patient just to say, I'm here for pain. Because some people, actually, it's not fair to tell you frankly, because some people will have pain and you can see it and prove it and everything. But the problem is, one rule has to apply to everyone. You need to be consistent and fair. So either you open the door to everyone or close the door on everyone. And because it's very tricky, sometimes I sit and I tell, is this the psychological bit doing it? Is the sensitization doing it? Are they making it up? And some people are very smart. Even as a clinician, I'm not telling you I'm confident enough that I will pick everyone. And I'm not there. I'm actually, most of the time, I'm trying to help the patient and saying something to help them just to put their feet. But sometimes you come across that. The 5%. I think some of the audience ask about CRPS, complex regional pain syndrome. From its name, it sounds complex already. But it's simply, it's not common condition, which is good because it's sometimes not a nice pain condition. There is two criteria which I'll share with you quickly. So simply, there is International Association of Study of Pain, have their own criteria, very well regarded. There is a criteria to diagnose this condition. Simply what it is. In a simple way, usually it happens in a limb. Someone went for operation in a knee replacement, ankle injury, a fracture, and they had a surgery or a repair or whatever. And rather than improving, they start to have all sorts of pain in this limb. And funny colors, funny temperatures, even you cannot touch the skin changing colors, just touching them will hurt, atrophy in the muscles, criteria which we'll talk about. Why all this happening? Pretty much the glitch in the nervous system. The nervous system overreacted to the insult. So rather than just reacting to it as any injury happen in the body or any surgery and we will recover, the nervous system of the patient overreacted and gave us CRPS. So what's the criteria? Pain out of the equation. You're telling me this is very subjective. Yes, but see the rest of the criteria. The patient have to report symptoms are what the patient complaining of. So this is something the patient report. One symptom in 3 or more categories. That's the categories, 4 of them. Signs, what we see as clinicians, at least one sign in 2 or more categories. And then nothing else to explain that. So we didn't see that they missed repairing a tendon, something which keep triggering the nervous system. Sometimes it happens. Some people come as CRPS, and we start to look and dig a little bit more, and tell, maybe the surgeon missed that. And we do a scan, and we found, and we send them back, and they got repaired, and then when they got repaired, the system calmed down. It's not common, but it does happen. So what's the criteria? Sensation. I used simply before studying pain, even as another clinician, when patients sometimes touch the area of the pain and they tell me this is hurting, I didn't use sometimes to believe them. But that's my ignorance. There is something like such. Sometimes the nervous system can be very sensitive to the extent that just touching the area will hurt. Sometimes you put a pin. A pin is a pin. If you touch me with a pin, I should feel it like a pin. You're just very small pin going through. Patient will feel it like a knife, as if you're putting knife through them. That's what? That's the sensitization. That's how we diagnose this stimulation of the nervous system. So that's part of the sensation. Vasomotor, simply temperature changes in the limb or color changes. This pseudomotor or edema, simply there is swelling in the area, in the limb, or there is sweating changes. They're telling you this side is more sweaty than this side. This side is less sweating than the other side. And you feel sometimes, especially in a hot day, and you put your hand and you feel, yes, this is more sweaty than the other side or less. And you can tell. Even you see the atrophy. They are not moving the limb. They cannot move it because the nervous system is that defensive, you shouldn't move that. And you see the wasting in the muscles. You see sometimes even the hair falling. Nails atrophy. Sometimes you do bone scan and there is even atrophy in the bone. So if you have this criteria, you diagnose CRPS. Where they got this criteria from? From the next slide, which is actually more, that's something called Budapest Diagnostic Criteria, very highly regarded, was issued in 2015. Same one, pretty much. They got the other one from that one, but it's simply the same thing. How you assess impairment from CRPS? You can. Yes, in AMA 5, but also you can do it here. How? Because you can leave the pain alone and you can judge that the muscles is not moving. You can tell that there is actually impairment because simply the bone scan showing atrophy in the bone. So sometimes if we're going to fight about the pain and the pain is subjective, leave all that alone. Let's talk about the sensation. Let's talk about the muscles, the atrophy in the nails, things which you can see and prove to anyone that there is impairment happening here. So you can actually get points for impairment, for the sensation, for the motor function. Something they're doing just to add a little bit of complexity to it or make it more regulated. Not one doctor or one clinician, at least two. And it has to be for more than 1 year. From a medical point of view, you can diagnose CRPS after a few weeks, after a month, whenever it happened. You don't need to wait for a year to diagnose it. That's the legal bit of it. And again, you cannot say that this is happening from something else. The easy one to relate to if they miss something which is triggering the system. Or it's completely different diagnosis. Sometimes some nerve pain or nerve injury can cause similar symptoms with difference. Sorry for this very bad photo. I tried to get better resolution one, but I couldn't. But I want to show you this one. Can anyone tell me what I'm trying to say in this photo or picture? We used to show this to the patient in the pain education program, telling them, where are you? And they tell me, what you mean? I tell you are here in the picture. Where are you? So simply, we are down here. We're trying to help. But the patient has to do the effort, have to move. We're just giving them a bridge or aid. And that's why we come to why work cover, and I'm sorry to say that, but I'm telling from real life experience, or insurance or court cases don't do well. A lot of chronic pain patients don't do well. But why this particularly? Because simply there is no motivation to walk that bridge, even if you put it for them. It's a reality. I see it even with the work cover who come and see me as a pain physician. The things I offer to normal people have better result than what I offer for insurance or work cover. So there must be something happening here. What it is it the mental conditions and the over layers of stress from cover work and things? Is there a secondary gain which is not making them put the effort? Who knows? They don't tell you, frankly, like the normal patient who wants your help just for the sake of finding a way out. I had people, sorry, just to interrupt. I have a nurse who was very keen to go back to work. And I found that people love their work environment, very keen to go back to whatever they were doing and move on. They do well. Just have a treatment for a few weeks, and she was back full duty. But that's one of very few work cover cases I saw and treat. And also there is a lot of different opinion, a lot of trauma, a lot of promises and nothing happened, and things doesn't go well, and they lost trust. But I'll tell you something I usually say for the independent, or even with the work cover. When the work cover people come and tell me, you need to write a report to tell my work cover how much I'm impaired, I'll tell them I'm here to try to help you with the pain. I'm not going to write any reports. So if that's what they are after from me, they start to disengage and disappear. And they go complain to the claim worker, he's a horrible doctor. I didn't mean to be horrible, but it's simply, I'm upfront with them. I'm here to try to help you to come out of that. I'm not here to write a report that you cannot do the job so that you get more claims. It's not my role here. I'm dealing with you like any other patient who come to my room. I'm forgetting that you're a work cover or insurance. Another thing with the independent, when they come before I do anything to them, they are very tense from you because I'm the one who make them pass or fail. I told them we're not in an exam here. I'm here to help you. Tell me whatever, I'm independent. I even sometimes ignore who actually sending for the report, which side. Because whatever I'm saying, I'm not going to try to please whoever pay for the money for the patient or the claimant. So I say that to the patient. I'm very independent. I'm going to say things as I feel. You may like it or not, but I'm telling you frankly, I'm not biased by any other parties here, and I don't want to be part, I call it the game. I listen to them like any other patient, but I would still put my impression like any other patient who come to my room. Yeah, but that's what I'm giving as a hint in the room. Sometimes you may invest in the pain education program, which doesn't necessarily have to include a pain specialist. Sometimes you go to us and we don't offer much, or just do a procedure on intervention and stuff like that. But what I want to say, actually sometimes getting more information to them from different people and try to engage them, it may save a lot of things down the track. So sometimes even as an insurer or a lawyer or whatever, if you really want to think about cost effective, sometimes you may invest into other things which we usually get to at the end or down the line because it may change the outcome to some people. Some people are genuine, they're just struggling. They are not making it up. Not every work cover will be making it up. We said it's 5% overall. That's not much. It's not much if you think about it. 95% are genuine people who are struggling. The skin, the allodynia, what we call allodynia, which simply, if you come...
No, central sensitization, not complex regional pain syndrome.
Yeah. So simply, complex regional pain syndrome, we talked about changes in the color, changes in sweating and things, but central sensitization is very localized to the area. So I'll give you an example. Chronic low back pain. Initially start like a pain, very localized, come and goes and things like that. With people who become sensitized, you sometimes can do a scan, nothing to explain the extent of the pain and the severity of it. But you see that the pain was initially start at one level, whatever, lumbar spine 3, whatever. But over time, the pain start to spread up or down or to the sides. That's one. The pain initially comes and goes, and just in relation to movement. Now the pain constant. And even you can rest and don't do anything and you're still in much pain. That's all subjective still. The patient is reporting that. But some people will not know that if you touch them, it should hurt. And sometimes I even don't touch them. I have something called the brush allodynia. You got a brush and just run it, and you don't run it initially in the area. Run somewhere else. How you feel? In your forehead, here, and then you go to the pain and brush. Tell you, this is hurting me. It makes me feel like as if you're putting a pin. And then when you put the pin, this is feeling like a knife. Unless someone feeling that, they will not be able to describe that. And then they cannot move because the nervous system becoming more defensive. You shouldn't move. And imagine if someone now it's becoming sore to the extent that just touch will hurt. What about if you ask them to move this part? So you can get a clue what's happening. And then you can ask family. They tell you a lot of them have chronic pain. Are you sleeping? I haven't been sleeping for a few years. How is the mood? Down. From what? A lot of things happening. Substances. Even sometimes some drugs, opioids, sometimes can cause sensitization. So sometimes opioid they meant to treat the pain, but in some cases they can actually trigger more the nervous system. I will tell you something. If you have, for example, something inflamed here, got broken or bruised or something, if I touch you here, you shall tell me, don't press too much, but it shouldn't hurt when you touch it. And it should just hurt where it's swollen and red and bruised and things like that. It shouldn't be around a very area which even look normal to you, and there's nothing wrong with that. And again, if you're expecting an inflammation there and you can see it there, you say, okay, there is inflammation here, there is a swelling here, it will explain that there is pain here. But if none of that exists, or whatever is there is very minimal to explain the severity or the extent, then you start to suspect. It's not anymore the hardware, it's the software. I usually say to patient, you can feel pain because the hardware issue, we can get it on a scan, we can see it, and there is a software. The system can glitch, but you can look to the computer and it look fine. Look intact, connected, the screen fine, all the wires are good, but it doesn't mean that it's working well. It can glitch. Same with our brain. And when you start to speak simple language to the patient, you start to relate and start to make a little bit more sense. Actually, the tricky bit is not that. The tricky bit, which one is psychogenic and which one sensitization. To see sensitization, or say definitely sensitization, you shall see that these signs that it's not anymore just that there is pain in the area, it's more intense. The alarm is going up. Sure. So I don't like to call them receptors, I will call them areas in the brain, because the brains are different regions and every region have a different function. So yes, we said that there are different areas, but there are similar areas when it comes, or a lot of overlap between areas, between chronic pain and mood or depression. Back to your question, as pain, we don't use antipsychotics to treat pain. I will tell you something, which a little bit different, but with antipsychotics, I don't use them. Most pain specialists don't, but if you go to psychiatrists, sometimes they prescribe them, or even GPs, for whatever. Because sometimes they prescribe them not for the pain, but just to make the patient sleep. Because one of the side effects of the antipsychotics, it makes people sleep. But if you look at it as a drug, what antipsychotics do, they make people feel a little bit sluggish and put weight. Is putting weight going to be good for someone you're trying to encourage them to move?
No.
Or even try to go to see the physio or the psychologist? Sometimes if you push too hard with this medication, they don't even have energy to get out of the couch, plus that they didn't sleep well the night before.
I came across a girl that was anorexic, and she was being treated long term with antipsychotic because it increased her appetite and helped
Her mood.
Yeah.
Yes. Yeah, but you're talking about eating disorder.
Yeah, I know, but I was just wondering when you were talking about those receptors, because I just thought the people that I come across, and we do come across a lot of them on the psychotic spectrum, pain's not their issue, and I was just wondering if
As far as I know, for me and most of us, we don't prescribe antipsychotics for management of pain. But I'll tell you something interesting, and I had the privilege in Tasmania to work with mental health team and a lot of psychiatrists in a mental health facility. They were trying TMS. Have you heard about TMS? Transmagnetic stimulation. Actually, I did the training, and I may be the first. No, that's the magnetic, transmagnetic stimulation to the brain. They use it a lot for depression and a lot of mental health disorder, PTSD and anxiety and things like that. So I was interested I did a training as a pain specialist, and they told me, why are you trying to come into that field? I told them, because at the moment we're talking about the same areas, and if these areas can be improved by transmagnetic stimulation, why not that maybe triggering this area or similar or nearby area may do something to the pain. And we're doing something similar at the moment with laser, medical laser, low-level laser therapy. So the trend at the moment, Lyrica or gabapentin. So if someone pretty much will not prescribe opioid, the doctors usually prescribe pregabalin or Lyrica or gabapentin, which is from the same group.
I've heard some really bad things about Lyrica.
Yes. I'll tell you frankly what it is. It's simply Lyrica was initially, when it was manufactured, was an anticonvulsant. It anti-seizure. If someone in a convulsion, if you give it in a high doses, you can stop someone from convulsing. That's how powerful it is. But we start to find that using it in a very low dose can help nerve pain and sometimes can help this sensitivity in the nervous system. But the problem with it is usually if you go with what recommended from the drug company for it and you go already with the recommended doses, you usually hit side effects. What's the side effect? Putting weight, drowsy, impaired cognition. Some people can become suicidal, swelling in the legs. But there is another one which no one is talking about at the moment, but in the UK they already alerted. Addiction. Why addiction to Lyrica? Because again, when you take it, it works on an area in the brain which makes people less anxious. And people start to take it not because of the pain anymore, it's simply numbing them.
Is the Lyrica?
Okay, I'll comment about medicinal cannabis.
And in terms of side effects?
Yes. So just before I move from the Lyrica, in the UK it's a controlled drug like opioid now, the Lyrica. At the moment we're still not at this stage. I think the government is leaving a room to patients and doctors. Okay, we took the opioid from you, we leave the Lyrica and the cannabis at the moment. But it will come to the stage that Lyrica will be next. But back to medicinal cannabis. Is it the magic drug which will fix everything? Before it got legalized, I was interested to know about it because I know that it was coming, that it will be approved. So I thought, okay, I'll become neutral. I will read about it like any other substance or any other drug. What's good about it, what's bad, how it meant to work, what shall we expect from it. And as I said to you, I work also in addiction. So I used to see people who are addicted to cannabis. So when it got legalized, I was knowing all about it. So if you go to a lot of pain specialists, as soon as you mention medicinal cannabis, they tell you, can you please don't talk about that? It's refused. Declined.
Isn't it no THC, the medicinal cannabis?
There is two parts,
Okay.
CBD and THC. But again, I was saying to the patient, do you know much about medicinal cannabis? No. Why you want to try it and what you expect or what you were told it was going to do. And I will tell them about the types and the side effects and what they shall expect from it. And then tell me, can you prescribe it? No, I don't. Why I'm not prescribing it? Because I see it like any other drug. It has a good side, it has a bad side, but I see that its bad side is more than the good side. And if I prescribe it to the first patient, I cannot say no to the next patient. The other thing why I don't prescribe it, the drug companies are making a lot of money from selling it. What if the patient in front of me coming and telling me, I cannot afford that, can I buy it from the street because it's cheaper? Ethically, what I would say to them, CBD, there is two components in cannabis, CBD and THC. CBD is good for sleeping, good for mood disorder, and people are depressed or anxious. And if the main player for the pain is mood or the lack of sleep, sometimes CBD can help the pain, but indirectly. Does this make sense? And CBD doesn't make people drowsy, doesn't make people addicted. You can easily drive on it and nothing will happen. When you add the THC to the CBD, that's the full cannabis. THC is going to work for the pain, but I'm sorry to say to you that how THC meant to work, it stopped the signals going to the brain, but it doesn't pick and choose the pain. It blocks everything. Yes, it's dose related, and depending on how much dose you are using, but the cannabis itself, why it make us doped, or the cognition is not good, or even we can make accidents, because it doesn't just pick the pain and stop it. It stops all the signals going to the brain.
But I thought medicinal cannabis was no THC.
No, there is two parts. You can be having CBD only, or you can have THC only, or you can have CBD plus THC.
So do you say that cannabis with the CBT only would be a useful?
Yeah, but unfortunately with the pain, it's not the best unless the only player for the pain is the mood
Okay, gotcha.
or the placebo. Sometimes, unless I give you something, the brain will not buy into it, even surgery, even anything.
So what medication do you prescribe someone that's got chronic pain?
I will tell you, I said opioids are not good, but if someone 80-year-old coming and he or she are struggling with arthritis and they cannot take an anti-inflammatory because of the contraindication and it will affect their kidney and stomach and whatever, Panadol is not enough. Will I come and tell to this elderly, I'm not going to give you opioids because it's addictive? The nervous system mellow down usually after the age of 65. It's not interested like anything else in the body, slowing down. So people don't get hooked.
So opioids over 65.
Not to everyone, but in general. And again, it's simply tolerance. The problem with opioids, why we usually lose the battle, even if not someone is not addicted, after a while from using them, the nervous system get used to it and tell me, if you want me to do the same job, give me more. Again, that mellow down usually after the age of 65. So sometimes you may start patient on a patch, 5 milligram or 10 milligram, and they will die with it. They didn't increase the dose or anything. Why is that? And people say, how come someone who's 20 years old, every 2 weeks coming and telling me it stopped working, put it up, put it up. So you don't have the same problem. The problem you have with the elderly, they can fall from the opioids if you push too much on it because it still affects the cognition. But again, Lyrica, I use Lyrica sometimes, but to the right people, which I feel that the risk of addiction is very low, and I don't listen to the drug company. I tell them, we're going to try this drug in a very low dose to avoid the side effects. If it works, we can build on that. If it's not going to do anything, I'm not pushing my luck and your luck with it. I'm not. I'm out. Cannabis, I say to patients, in some cases, it actually works well for people with cancer pain, especially if everything else didn't work. Doesn't matter. Even if it block everything and it worked for them, why not? Give them just some comfort.
So there's no one fit for all.
Exactly. And you need just to choose with them.
And it sounds like you've got to deal with their mental health really early on to get rid of that prejudice so that you won't.
Provided that patient acknowledging it as well, because you can say whatever you want to say, unless we put it on the table and do something about it, it's not going to go anywhere.
But if you do try and deal with that, then all you've got left is the real pain to deal with and hopefully it's less.
Or sometimes you say, if we actually on top of the mood, the pain may get better even indirectly, or another way, because again, we're talking about same chemicals, same areas in the brain. There was a question? Yeah.
Firstly, I've been in this industry for 15 plus years. I've never had a pain physician promote medical cannabis, so you're consistent with all the other physicians. I guess my question to you is, when we refer to an IME...
No, but sorry to interrupt you. I'm actually more open to it than a lot of my colleagues, because simply I know about it. Even some patients tell me if they want to prescribe it, yes, you can. In your case, we exhausted a lot of other things. Why not? But I usually give them a lot of information, and I told them, sorry, I don't prescribe it myself because I don't want to open the door. So I'm actually not against it, but I'm very neutral about it like any other substance, and I don't want to put my signature on it. I will tell you what I usually do. You remember the slide of pain presentation, the 5 type of categories? That's the first thing, is the diagnosis actually that which part of pain will it fall under out of these 5. And without a diagnosis, you will be all be blinded. What's happening? And we throwing things and getting it. So initially, is the diagnosis have been reached and we agree about it or not? The next question will be what to do about it. Depend on actually the type of patient, the group of patient or the cohort of patient, the whole given. You look at the patient as a holistic. What their comorbidities. Sometimes you want to try a medication, you cannot try it because they are on drugs which will interact. It's contraindicated, stuff like that. So again, everyone is different. And some people tell them, I think you may benefit of, some people I tell them, I thought that you would benefit of that, but they proved me wrong. They tried something else and it worked better. Our role, I will tell you something. According to research, our success as pain specialists or as clinician for managing chronic pain is 20%. That's very low. for a chronic condition, success rate 20%, general, not work cover, is 20%. Part of it is our fault because we are not adopting or accepting the physio, the psycho, the acupuncture, the laser, wherever still we don't know about. We are not adopting that. We just want to prescribe or inject or do ablations. And that sometimes will not work with that type of pain we talked about. So that's part of why you're failing. But part of it, we still don't know everything. And again, is the patient ready to do something or not? Remember the last image, unless the patient actually willing to push with us, we're not going to go anywhere. You can push whatever you want and recommend things. If the patient doesn't have the motivation to do something about it, the pain is not going away. That's from experience. Like seeing patient every day, sometimes even from the first consult, you know who will do well and who's not going to go anywhere. You don't say to the patient, of course, but you can say to the patient simply, you still have to be clear and upfront and give them a clear advice. Unless you put effort, we're not going to get anywhere. Does this answer? It's a very gray, but I discussed a lot of things. That's what we know so far. I'm not against anything, and anything I offer to patient, I usually say benefit risk. If the benefits are more than the risks, we can take it. If it's equal, you would say, is it worth it? And we need to justify doing that. If definitely the side effects are more than the benefits, I would say I cannot do that because of that. And a lot of people, once you explain to them why you cannot or you don't think it's a good idea, the majority will be fine with that. A lot of people just want us to talk. Explain to them what we're doing and why.